The New Jersey Center for Tourette Syndrome and Associated Disorders, NJCTS, its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate for any treatment. You are responsible for your own medical decisions. Now I'm going to turn over the introduction of our speaker to Martha Butterfield, the webinar coordinator of NJCTS. Marty?
Kelly, thank you, and good evening, everyone. We're delighted to have Dr. Ewbank speak tonight about our Rutgers University Tourette Syndrome program. It is the only one of its kind in the country. Established in 2000, it's a unique partnership between Rutgers University and the New Jersey Center for Tourette Syndrome. Its purpose was to create a new generation of doctors skilled in treating TS. Doctors from this program are now in various positions all across the country working with families, adults, and children living with TS. This is Dr. Ewbank's third appearance in our webinar series. His two previous presentations on building positive environments and rage behaviors can be downloaded from our website. I will get to his official introduction in just a moment, but before I do that, I have a couple of things I want to call your attention to. Our fourth annual Mendham Walk is on November 23rd, and that's only 24 days away. We hope you will join us that day, make a donation, support the NJCTS team, or form your own team. If you can't be there to participate, please log on to our website and make a donation. Funds raised will go to support our School in Service program. The other item I want to mention is that effective November 1st, there will be a $20 fee for webinar attendees who wish to receive professional development credits. This will allow us to continue funding this very important program. Now to my introduction of tonight's presenter, Dr. Shawn Ewbank. Dr. Ewbank is the Clinical Director of the TS program at Rutgers University's New Brunswick campus. He is a clinical psychologist with expertise in the treatment of TS, OCD, ADHD, anxiety, behavioral problems, rage attacks, depression, and trichotillomania. In this capacity, he supervises and trains doctoral student therapists in cognitive behavioral therapy. His past and current research focuses have been on the evaluation and treatment of individuals with TS and multiple other disorders, and on the effectiveness of habit reversal training for individuals with tic disorders. He is also a senior psychologist at the Manhattan Center for Cognitive Behavioral Therapy, where he provides evaluations and CBT for adults, children, and adolescents. In addition to this, his current work, he specializes in group psychotherapy and in short-term therapy for college students. So without further introduction, I'll now turn tonight's presentation over to Dr. Ewbank.
Thank you, Marty. Good evening, everyone. I would like to thank the New Jersey Center for Tourette Syndrome for inviting me to speak tonight. I want to give a special thanks to Faith Rice, the director of NJCTS, for her unwavering support of the Tourette Syndrome program and of me personally. Faith and NJCTS are the glue holding together a wealth of services and opportunities for individuals and families with Tourette Syndrome in the state of New Jersey and beyond, including this Wednesday webinar series, which offers such a fantastic educational experience for families, teachers, health professionals, and any interested citizens. I also want to thank Marty and Kelly of NJCTS for guiding me through this webinar process and for answering all of my questions every time I have called over many, many years. Tonight, I am excited to have the opportunity to speak about the Tourette Syndrome Therapeutic Program at Rutgers University. My goal this evening is to spread the word about the TS program's unique role in helping individuals and families with TS. To do this, I will describe the program overall. I will introduce the various therapeutic solutions that we offer for TS and for difficulties that are commonly associated with TS, including OCD, ADHD, behavioral difficulties, rage attacks, anxiety, body-focused repetitive behaviors, depression, and general conditions for individuals with TS. I will talk about clinical research done by the TS program. Lastly, I will explain how to contact the program and what to expect from the initial phone call and from the evaluation process. Let me start off by acknowledging the potential challenges faced by individuals and families looking for help with Tourette syndrome and other related difficulties. We live in a world where a lot of doctors, psychologists, and other professionals within healthcare and educational services often lack a fundamental understanding of tic disorders, and where those with basic information lack the sophisticated knowledge required to give optimal advice. We live in a world where the few of us who are privileged with the level of education, training, and experience that allows us to declare ourselves experts in Tourette's can remain inaccessible to those who could most benefit from our aid. From the point of view of a parent, it can be hard to determine who the experts are and which experts may hold the solution for specific problems. Worse still, identified experts can be hard to afford. Identified experts may not work directly with health insurance companies because insurance companies pursue their own profit interests by placing barriers between the patient and the doctors with the best qualifications. The challenges within this healthcare landscape may sound bleak, but they are not insurmountable. In the state of New Jersey, the New Jersey Center for TS has engendered a network of service providers within the fields of neurology, psychiatry, nursing, education, social work, consumer advocacy, and psychology. Representing psychology, the Tourette Syndrome Therapeutic Program is part of NJCTS's vision. In 2001, NJCTS approached the Center of Applied Psychology at Rutgers University and proposed a collaboration through which our clinic was born. In accordance to the vision, the TS program was designed to provide cutting-edge therapeutic services that would be affordable to families. The TS program was also created as a training clinic where graduate students pursuing their doctorates in clinical psychology could become experts in the evaluation and treatment of TS, thus spreading the availability of services over time throughout the state of New Jersey and beyond. The TS program is a psychological clinic that works almost exclusively with children, adolescents, and adults with Tourette syndrome and their family members. Let me outline what we do at the TS program. We conduct comprehensive evaluations to diagnose various neurological and psychological disorders and to help individuals and families gain a more complete understanding of emotional, functional, social, and behavioral challenges that can be a consequence of having TS or other disorders that are commonly occurring with TS. We offer cognitive behavioral therapy, or CBT, focused on providing information, giving emotional support, and teaching skills that decrease various difficulties that come along with Tourette syndrome, including management strategies for decreasing the tics themselves. We coordinate with medical doctors, teachers, advocates, and experts in the field of TS in our efforts to offer and coordinate the highest level of care. We do all of this while providing intensive training and supervision to graduate students within one of the top clinical psychology programs in the country. By doing all of these things, we honor our mission to improve the lives of individuals and families with TS while supporting the NJCTS mission to increase awareness and expertise in TS within the healthcare and education landscapes. I would like to spend some time talking in more detail about the therapeutic treatments offered by the TS program. Any individual with TS or parent of a child with TS can benefit from knowing what treatment options are available for various potential challenges. At the TS program, we specialize in psychological treatments that are informed by cognitive behavioral therapy, or CBT. CBT focuses on the ways that neurology, thoughts, and actions can contribute to problems and teaches skills focused on thinking differently and acting differently as a way to manage problems. All of the CBT treatments that we offer have a body of research that demonstrates that the treatments are helpful for most people. While many of the disorders that we treat do not have cures, CBT can often lead to significant decreases in symptoms and increases in well-being and functioning. Each of the treatments that we offer could be a topic for its own webinar. For today, I am going to give a brief description of the different CBT treatments for tics, OCD, ADHD, behavioral difficulties, rage attacks, anxiety, hair pulling and other body-focused repetitive behaviors, and depression. The behavioral treatment for tics is called Comprehensive Behavioral Intervention for Tics, or CBIT. CBIT is also referred to as habit reversal training, or HRT. HRT predates CBIT and can be considered a less comprehensive version of CBIT. The change in name was a good one. Since tics are not habits, it is a little bit pejorative to refer to their treatment as habit reversal. That said, we welcome referrals for CBIT or HRT. We will treat the tics the same way regardless of the terminology. So what is CBIT? CBIT teaches individuals with tics management strategies that can decrease selected tics over time. It can work well in combination with or as an alternative option to medication for tics. CBIT teaches three main skills for the management of selected tics. First, awareness training helps individuals to consistently recognize cues that a tic is about to happen before it happens. Second, stimulus control modifies the environment in places where tics are high in an attempt to decrease the urge to tic. Third, competing response training teaches individuals to replace their tics with incompatible actions that serve as alternative to tics, helping to hold back a tic until the urge to tic decreases. Sounds easy, right? Indeed, learning the basic ideas of CBIT is pretty straightforward. However, professional expertise is usually required to navigate the unpredictable challenges that arise within most CBIT treatments. In an ideal treatment, an individual learns two things. First, they learn specific strategies that reduce current problematic tics. Second, they learn the general ideas for how to apply their strategies, becoming experts at managing future tics. In addition to the main strategies of CBIT, there are secondary strategies that are useful for a lot of people, including relaxation, greater acceptance of diagnosis, management of negative thoughts about tic urges, and management of OCD that relates to tics. There is good scientific evidence that CBIT works well for children, adolescents, and adults with TS. The current published research focuses on children who are 9 years old or older. However, at the TS program, we have done some successful, slightly modified CBIT treatments with motivated children as young as the age of 5. Beyond the research is my extensive personal experience with CBIT. Admittedly, when our clinic first heard about the treatment in 2006, we were skeptical that tics a consequence to neurological circumstances, could be decreased with behavioral interventions. We looked at the developing body of research and decided to contact some of the researchers to learn more about the approach. I remember initially working with a teenager with a piercing, shrieking tic. He was out of school and socially isolated, humiliated by the reality of uncontrolled disruption. Desperate and motivated, he dedicated himself fully to the treatment intervention. Within a couple of weeks, this long-standing tic was completely under control. The urge to perform the tic was still present, but it was so reduced that managing the urge was easy and done with little thought or effort. Initial experiences such as these sold the TS program on the utility of CBIT. We became believers. As many in the TS community know, tics are often accompanied by obsessive-compulsive symptoms. Cognitive behavioral therapy for OCD is called exposure and response prevention, or ERP. Therapy begins by learning fundamental skills about how to manage the anxiety associated with OCD. Following this initial education, session time is spent practicing the skill of defying OCD rituals and tolerating OCD-related anxiety, first in ways that are easy, then in ways that are progressively more challenging. The process of tolerating OCD-related anxiety is called exposure. During exposures, anxiety will slowly come down on its own without an individual having to perform an OCD ritual. After clients become good at exposures within the therapy meetings, they can begin to practice exposures between sessions. With repeated practice of exposure, targeted areas of OCD anxiety tend to decrease. At the end of a successful treatment, an individual should feel confident to manage OCD on their own. CBT for OCD works well for adults, teens, and children and can be used in combination with or as an alternative to medication. Let's move on to ADHD. ADHD is a tough disorder for many children and families. While ADHD cannot be cured, there are many ways to manage the disorder and to decrease the risk of impairment over time. Many individuals with ADHD can benefit from a stimulant or another ADHD medication. With or without medication, daily behavioral management of ADHD can maximize the ability to be successful. Cognitive behavioral therapy for ADHD begins by teaching children, teens, and adults with ADHD how the disorder works to cause difficulties in multiple areas. CBT also teaches parents what role they can play in helping their child to be successful by knowing when to offer help versus when to maintain expectations. A good understanding of ADHD is the first step to anticipate where and why problems occur and to create management strategies to address core issues. Session time is spent planning and implementing various management strategies for issues such as motivation, procrastination, organization, homework, deadlines, oppositional behaviors, and interpersonal relationships. When ADHD or other difficulties are leading to overall problems with following directions or behavioral difficulties in the home, the TS program will often recommend parent management training. Parent management training involves weekly therapy sessions with one or multiple caregivers of a child. Since the treatment focuses on the parent's ability to work effectively with their child, children do not come to every session. Session time is spent training caregivers in various skills that are then applied at home. Core skills in parent management training include successfully giving directions, administering praise and reward, effectively using timeouts, when to give attention versus when to ignore, and teaching positive behaviors by breaking things down into small steps. Many parents who decide to try parent management training have tried similar approaches in the past, either as part of their general parenting repertoire or as part of behavioral plans directed by well-intentioned counselors. Parent management training tends to be more effective than other behavioral plans because it focuses on the specific details that make strategies such as praise or timeouts effective. As parents learn how to use these strategies well, they will also understand why they did not work in the past. When behavioral problems are characterized by explosive outbursts or rage attacks, we recommend collaborative problem solving. Collaborative problem solving is an ideal approach when explosive outbursts or rage attacks are a common occurrence. It is the behavioral treatment of choice when rewards programs and consequences have proven unsuccessful or when outbursts are clearly out of a child's control. Collaborative problem solving focuses on identifying lagging skills that cause outburst behaviors. For example, some children have a lagging skill in the area of flexible thinking. When something happens that is different from their expectations, they may quickly become upset. Collaborative problem solving teaches parents how to anticipate when outbursts are likely to occur and what causes them. Once problem areas are identified, collaborative problem solving teaches both parents and children a specific style of communication that leads to mutually agreed upon solutions. The approach is designed to lower the number of outbursts while teaching the child skills in areas where they are lagging. The ability to teach the child needed skills while reducing family tension brought on by the outbursts makes collaborative problem solving a powerful treatment option. My first case within the TS program involved a child with daily explosive outbursts triggered by any event that did not match her expectations. Over a period of 4 months, I worked with the family to improve communication, eliminate rage, and provide the child with greater skills in cognitive flexibility. Over the years, this family has spoken highly of the TS program, sending many clients our way. Their gratitude is understandable. Rage attacks can wreak such havoc on families. The family's dedication to following the treatment recommendations made all the difference in this case. Moving away from behavioral difficulties, CBT is also a highly successful treatment for anxiety in adult teens and children. It begins by increasing an individual's awareness of false alarms in thinking, overreactions to bodily sensations, and avoidance behaviors that disrupt day-to-day living. With increased awareness of anxious thoughts, sensations, and actions, individuals can begin to incorporate management strategies that promote balanced thinking, mindful reaction to bodily signals, and goal-influenced behaviors as an alternative to anxiety-driven behaviors. Consistent practice of these management strategies allows individuals to pursue their life goals without anxiety as a barrier. CBT for anxiety can be specifically tailored to children and adolescents. First, children learn to better identify and understand their negative feelings. Next, they gain skills in creating coping thoughts that can respond to anxious thoughts. If it seems useful, children will also learn skills in relaxation. As these initial skills are built, children become better prepared to face anxious situations. Once a child is prepared, treatment will target specific situations where anxiety gets in the way. In this phase of treatment, children practice facing their anxiety during in-session exercises that they learn to incorporate into life outside of session. As children gain confidence in facing anxious situations, their overall anxiety tends to fall. Throughout the treatment, parents are kept well informed of what the child is working on and of how they can support the child between sessions. I know I mentioned how tics are not habits a little bit earlier. That said, as a psychologist who is skilled in behavioral interventions for tics, I am also skilled in behavioral interventions for various habits, including hair pulling, skin picking, and other body-focused repetitive behaviors. CBT can effectively decrease pulling or picking in adults, teens, and children. The treatment actually does use the name habit reversal therapy, or HRT, and is quite similar to CBIT for tics. To introduce a little bit about what treatment looks like, I will focus on hair pulling. Therapy sessions focus on teaching the skills of awareness training, stimulus control, and competing response training. Awareness training allows individuals to become experts in their pulling habits by keeping close track of when, where, and how much hair is being pulled. Stimulus control modifies high pulling situations in ways that decrease the likelihood of pulling. Competing response training teaches individuals strategies to tolerate urges to pull while using techniques that actively prevent pulling. When pulling is consistently disrupted within different situations, the urge to pull tends to decrease. Research has established that HRT can result in substantial reductions in hair pulling. Treatment for other body-focused repetitive behaviors, such as skin picking, nail cuticle biting, nose picking, cheek biting, lip picking, and skin biting, is identical to treatment for hair pulling or trichotillomania. For a detailed look at these treatments and for a detailed look at the treatments for OCD, I highly recommend you check out the NJCTS webinar archive, which has talks on both these topics. Individuals with TS can face a lot of challenges, including distraction, stigma, ruminative thinking, social difficulties, and embarrassment about symptoms. With so many things going on, it is not a surprise that some individuals with TS can struggle with depression. CBT is the treatment of choice for depression in adults, teens, and children. It can be used as an alternative to or in conjunction with medication. Treatment focuses on teaching skills for better management of mood by changing behaviors, balancing thinking, and decreasing physiological arousal. To change behaviors, individuals are taught behavioral activation, where they increase antidepressant behaviors and generate solutions for ongoing stressors that maintain depression. To balance thinking, individuals are taught to catch negative thoughts, to recognize thinking traps, and to increase mental flexibility in order to divert negative rumination. To decrease physiological arousal, individuals are taught relaxation strategies such as mindfulness, which helps people to better tolerate negative emotions and sensations. As children, adolescents, and adults incorporate skills over time, mood tends to improve, and the ability to ward off future episodes of depression increases. All of the treatments that I have mentioned focus on providing specific management strategies for specific issues. However, as I am sure many of you in the audience know, a lot of children and adults with TS can have multiple difficulties at the same time. Sometimes it can be challenging to fit a specific problem into the perfect category that determines what a family or individual should do. We see this challenge by teachers, doctors, parents, families, and individuals with TS who are trying to figure out the best course to optimal functioning and well-being. In 2005, when Dr. Lori Rockmore started as the clinical director of the TS program, and when I also started my work within the program, this challenge of what to do with these complex cases was foremost in our minds. Our clinic has been designed to address this challenge through our evaluations, trainings, and through the treatments we offer. When we think it will be helpful, we consult with other doctors and experts. More importantly, we are happy to reach out to the non-family member adults who have an impact on the child's life: teachers, schools, doctors, psychiatrists, coaches, and others. When there are big problems to solve, we like to collaborate and work as a team when possible. With our energy and collaboration, I wish I could say that we have found the perfect formula for every challenge. It would be great to always know exactly what to do. While we can't guarantee that, what we can guarantee is an approach to evaluation and treatment that keeps complexities in mind and that strives to use what we know and to collaborate with families on the solutions that make the most sense. With that spirit in mind, we are a clinic that likes to stay on the front line of psychological treatments and to improve what we do on a yearly basis. Most recently, we put our efforts into the development of a group program for children and adolescents with TS. The groups offer a general set of skills that are useful when you have tics. When we set out to determine what would be most useful for children and adolescents with TS, we decided to turn to the real experts, the parents of children with TS. In the spring of 2012, the New Jersey Center for Tourette Syndrome helped us to send out a survey that asked for detailed information about what skills children and adolescents with TS could benefit from. We were grateful to get a large response from everyone in the TS community. We took the information that you all provided to us and we redesigned our group program to address the agreed upon needs. To make sure we would get it right, the main authors of this group protocol, Dr. Mayer Fonsbaum, graduate student Amy Kranzler, and Dr. Lori Rockmore, worked tirelessly using knowledge from evidence-based CBT treatments for groups and individuals and from good old common sense that they had gained from their own experience within therapy work, summer camp, and parenting. From this knowledge base of your needs, research, and life experience, they created a group protocol that would work. And it did work. In the winter and spring of this year, we ran these new groups for the first time. The opportunity for the same group of children and adolescents with TS to interact together for 10 weeks in a row, working together, learning from one another, feeling free to talk openly about their tics, getting to hear about what it is like for others with tics, is inspiring. Not only is the opportunity inspiring, it is rare. In addition to the opportunity to interact with other kids with TS, the groups offer the chance for children to learn useful skills, including identifying and managing difficult thoughts and feelings, solving interpersonal problems related to tics, improving communication skills, and talking to others about tics and responding to teasing. Together, these skills and others are intended to build a child's resiliency, which from a psychology perspective means the groups decrease current and potential future problems in social and emotional domains. The groups are intended to help all children with TS, not just those who are struggling right now. In line with the goals of the New Jersey Center for TS, the groups help children to become advocates for themselves, giving them the tools to navigate challenges that commonly arise when one has tics. After the success of last year's groups, the authors decided that the group protocol was too useful to be an exclusive product for the TS program. They are in the process of turning the protocol into a book and in communications with various publishers. In the meantime, we are currently recruiting for the next round of groups that begins in 2014 in January. I encourage any interested families to contact our clinic to learn more. I want to touch on some of the research that we do at the TS program. By design, we are not a research clinic, but a service-oriented training clinic. However, we have come to realize that there are some unique ways that we can contribute to the growing body of treatment research on TS. One example of this involves the group curriculum that I have just discussed. We hope to begin collecting data on the usefulness of our groups starting in 2014. Our ability to learn about these groups through research may help to build awareness of our group program as a great resource for other clinics. Also, it will help us to continue to make improvements to the group. Another example of our research is our ongoing study on the effectiveness of CBIT for ticks. Recent studies have established the efficacy of CBIT within a closely controlled research environment. Our study hopes to add to the current evidence by looking at how well CBIT works when administered in a community clinic setting where clinicians have more flexibility to respond directly to the individual client needs, because they do not have to adhere as strictly to a predefined research protocol. The research arm of our program would not be possible if it weren't for the hard work of Dr. Mare Flansbaum, who is the Assistant Research Director at the TS program. In addition, Dr. Flansbaum supervises student-driven research, which often leads to doctoral dissertations and supports our overall mission of training. Supporting student research is just one part of the TS program's extensive work in clinical training. Our treatment team consists primarily of graduate students from Rutgers University who are pursuing their doctoral degrees in clinical psychology. Students are attracted to the TS program because it pairs valuable clinical experience with in-depth training and supervision. The clinic's great reputation makes the application process quite competitive. There are many applicants and only a few spots open each year. As the director, I have the privilege to select and work with exceptionally talented graduate students from one of the most competitive and top-ranked psychology graduate programs in the country, Rutgers. Highly skilled students combined with intensive training has proved to be a formula for successful treatment time and time again. Within their time at the TS program, students are immersed in the clinical literature about tics, ADHD, OCD, behavioral issues, assessment, and much more. The students participate in weekly interactive seminars that serve as forums for learning about how to provide optimal care. As the leader of the seminar, I am always impressed by how much I learn from the students who consistently bring in the most up-to-date knowledge about clinical psychology and treatment. One of my favorite things about being the director of the clinic is being able to supervise the students' clinical work. I meet weekly with each of my clinicians and we talk about the cases while watching portions of their recorded therapy sessions. Again, the learning goes two ways. Just as the students learn from me, I learn from them. We all become better therapists in the process. The direction of each individual therapy case is a collaboration between the students, myself, the literature on both research and therapy, and, most important, the goals of our clients and their families. One of the advantages of receiving services from clinicians in training is the time and energy they have put into each of their cases. I am always impressed by the dedication shown by my team of clinicians. The TS program's great reputation is a direct result of these students' dedication. I hope that my description of the program and what we do has conveyed the passion that I share with my clinicians for making a difference in the world of TS. I encourage any individual or family with TS to keep our clinic in mind as an option for affordable services and great care. The best way to reach out to our clinic is by calling us at 848-445-6111, extension 40150. That number goes directly to our voicemail. Our phone coordinator picks up messages 2 to 3 times per week and then returns the calls. When you speak to the phone coordinator, they will take down some basic details and provide you with some information about how our clinic works. They will also answer whatever questions they can about our services. If you are interested in services, the next step is an evaluation. There is a short one-meeting evaluation for the group program and a more detailed evaluation for individuals or families who are considering therapeutic services or who are hoping for a diagnostic report from us. If you are interested in the group program, evaluations take place beginning in November and through January, and the groups begin in January. If you're interested in specific therapeutic services, it usually takes about 2 to 3 weeks between the initial phone contact and the time of the first appointment. After the phone call, the phone coordinator provides me with the information so I can assign the case to an available clinician who seems like a good match. That clinician will contact you to set up an initial evaluation appointment. Sometimes we have a waiting list, and it could take a little longer than 2 to 3 weeks. When this is the case, we will let you know how long you could expect to wait during this initial phone screening. Right now, we do not have a waiting list. Evaluations for therapeutic services are usually completed in 2 to 4 meetings. We gain the perspective of the children and parents by asking questions throughout the meeting and by asking you to fill some things out at home. The thoroughness of our evaluations allows us to make the best recommendations and to provide the best treatment possible. Well, I think that about covers it. I hope that my talk has helped everyone understand the TS program and what we do. Moreover, I hope that my talk has helped you understand the valuable services that we provide to the TS community. Thank you again for listening, and again, thank you to the New Jersey Center for Tourette Syndrome for hosting the talk tonight. And I am ready for questions.
Oh, are you? Good. I'm glad because we've got some.
Okay.
Couple of things that are probably kind of quick ones to kind of take care of right off the bat. You mentioned competing responses. What kind of a competing response would you suggest for an eye-rolling tic? Like, describe a little bit about how that works.
Mm-hmm. Well, I have to put a disclaimer on this competing response for an eye-rolling tic because eye blinking and eye movements, including eye rolling, are some of the harder tics to work with. So if we're working with a child or teen or adult who has a lot of tics, we usually will try to work on tics that don't involve the eyes first, allowing them to gain skills in CBIT before tackling harder tics such as eye rolling. That said, the competing response for an eye movement like eye rolling tends to be what I would call a shifting focused stare. Let me explain what that is. It's really finding a focused spot somewhere in your general range of vision, kind of focusing your eye on that spot. But of course, if we focus our eye in one place for too long, our eye quickly gets fatigued. So we pick a spot, focus on that for what seems like a good amount of seconds, maybe 3 to 7 seconds, and then we would pick another spot. And usually in therapy, we'll really practice doing this to help the individual do it in the most successful way. But it's certainly something people could try.
All right. Well, I didn't mean to pick one of the most difficult tics to work with right off the bat. Sorry about that.
Quite all right.
When you were talking about CBT, you said that, describe what you mean by motivated child. Like, are we talking age here, or what's the description of a motivated child?
Mm-hmm. A motivated child, in my mind, is somebody who early on in the treatment process says, yes, I'm willing to do this. You have skills and strategies that you're teaching me, and I'm on board. And motivation is particularly important for tics and for things like hair pulling or other repetitive habits. Without the motivation of the person who's supposed to correct these behaviors, you can probably forget it. So early in therapy, we really focus on trying to gain and increase motivation. Motivation is also pretty important for things like anxiety disorders and OCD, because we're really asking the child to work on things not only in session but out of session. The reason why I linked motivation to age at a point in my talk where I mentioned sort of CBIT for younger children is because motivation really has a developmental component. The older we get, the more we tend to be motivated to do things that have good long-term gains, like working hard on CBIT strategies because we want our tics to be decreasing over several week period of time.
So the child would have to practice whatever this is when they're not there, so there would have to be some inclination for them to want to do that.
That's right. And with a young child, I never hold an expectation that a really young child is going to walk out of my office and all on their own practice the strategies we worked on. So the younger the child is, the more the parent is really involved, and parents and possibly other adults are helping to create a structure to direct the child to practice. But with something like a tic, if the child says, I'm not going to do it, then in a way that's their choice. We can try to motivate them, but if eventually they don't say, I agree, it's going to be really tough to get good results.
Okay. We had a couple of questions on cheek biting. So could you talk about that a little bit? One question relates to an individual is 19. This other question doesn't give an age. So would you talk about that as a tic issue and what you could give advice on?
Yeah.
So we're talking about inside your mouth. So I'm talking about, biting inside your cheek.
Yeah. So, good. I was about to give that definition as well. So basically, let's think about cheek biting being two possible things. So it could be there's an individual with Tourette syndrome or a bunch of tics, and cheek biting is one of these tics. Or there definitely are children and adults who have cheek biting that's more of a repetitive habit of the similar things like trichotillomania, which is hair pulling, or skin picking. So either one of these might lead to cheek biting. As far as habit reversal or CBIT, depending on exactly where the cheek bitings come from, we might do slightly different things. But the bottom line is, when you think about a competing response, when the urge to bite cheeks is present, and if somebody is aware of that urge, then they're going to have to do something that hopefully prevents cheek biting from happening. The easiest thing that could work is that they actually close their teeth together without biting their cheek. So now they have closed teeth, but their cheek isn't being squeezed, and they're holding that kind of closed mouth or basically closed teeth position for a designated amount of time. It might be some individuals who have cheek biting. They might kind of do it more absent-mindedly, and so within treatment it could be that earlier on we're really working on helping them increase their awareness for exactly when it's happening, and maybe even making changes to environments where it happens a lot and trying to shift things in situations where it happens a lot so maybe it'd be less likely to happen.
Okay. Thank you. I have a parent asking for some advice regarding a 17-year-old college male who has TS and ADHD and OCD, but the student is living on campus and just unwilling to seek accommodations or counseling or to really, it would seem, to advocate for themselves. So it's created a difficult situation. Could you just address that type of student who finds themselves on their own for the first time and really, you know, doesn't want to step up and do some, take some action for themselves?
Yes, of course. You know, that's a really challenging situation, and partly because if you have a college student who's living on campus, even at the age of 17, they're essentially functioning as a young adult, and so to a certain degree, if they are not seeking help on their own, within a lot of the colleges, there can be a limited thing that can be done. However, that said, it sort of depends on what college the student is going to, because some schools are a little bit more hands-on than others, and if parents are really concerned, it might be that they can make residential advisors or the school counseling center or administrators at the school aware of their concerns about the child, and within some school settings, the school might really seek to actively intervene. You know, if even the semblance, any bit of motivation, if it could come in any direction with a child with a young adult with TS, OCD, and ADHD at college. At most colleges, there's a whole host of services that could probably be useful within kind of the counseling centers, but also just the tutoring centers and places where academic assistance could be made, possibility for modifications. And so it might be important to try to find some place where the student says, well, I'm willing to try that. And if you could actually, maybe afterwards, if you could send me an email, there's actually, if it's in the state of New Jersey has a pretty good service for individuals who have things like ADHD and another type of disorder. So if there's ADHD and comorbid OCD, you actually you're eligible for state services where you can have somebody come in who's not really a therapist or counselor, but can really help structure, make plans, and sort of more of like a mentorship program. So there are a lot of options. It's tough when, yeah.
Yeah, I'll forward you some information on that then. But it does lead to the very point, though, that kids, when they're in their middle and high school years, they really, I think, need to begin to become better advocates for themselves, to know where to go for services, especially when they get off on their own, and avail themselves of those services. But you have to be an advocate for yourself to do that.
Yeah, and I think that's something we both you guys and us, that we really try to promote. And you know, it's hard when you have an adolescent or a young adult who's struggling and not wanting to seek help or to advocate.
I have a question about panic and rage. Is there any evidence of a link between the two of them? This particular question has to do with a 16-year-old who mostly experiences rage but really doesn't have panic attacks. So is there any kind of a link between those that you know of?
Yes, if there is one, and if there's research on this, I don't know about it. But as you get into a lot of these different areas, particularly something like panic, I'm less familiar with the research on panic. What I can say with a lot of disorders, like if you have tics and then you have an anxiety disorder, OCD, and then you have ADHD, and the more things you're throwing on board, I think the higher likelihood that you have for rage attacks. And sort of in converse, if you're having a lot of rage attacks, that really tends to bring down overall functioning. So it's no surprise to me if anxiety disorders or depressive disorders sort of come along because of the stress that rage puts on an individual and it puts on their families.
Mm-hmm.
So,
well, there's no evidence for it. It seems like you would just, through your experience, would think there might be a connection there.
right. Well, I know of no specific evidence, but
Okay.
what I do know is if you have one thing, it's not surprising that you have other things
You
as
have
well.
the other, yeah.
Mm-hmm.
The parent programs at the clinic, are they, they're called, on your slide, you call them parent programs. Are they for both or either parent? Is it a family thing? Like, just tell me a little bit about the parent program.
Yes. Yeah, so we don't actually have what I would call at this point a parent program, but what you're referring to is a specific therapy that's called parent management training,
Mm-hmm. Okay.
which is one of these evidence-based CBT treatments that we use within our program, and think works really well. And this is parent management training is specifically designed for children who are having trouble following directions, who are having some level of behavioral problems, or maybe things around like homework or doing what's expected of them, or things like that, but maybe are less in the direction of having like rage attacks, which are kind of triggered events where they overreact to things in the same way. But a lot of times parent management training is used and associated with children who have ADHD, because I think the ADHD itself really makes it hard to do basic things like follow directions, and a lot of times children with ADHD, without a lot of structuring, it's hard for them to do what's expected to them. And so as a parent, I think a consequence of that is that makes your job, it can make your job a lot more difficult, and it can be useful to have like extra things to do to really help your child out. And when I think about this in the long term, the more a parent can do with somebody with ADHD over time to really help them, the more you can expect them to be independent and become advocates for themselves. So I don't know if that totally explains it.
But that management training, though, do both parents have to attend that?
Oh, right.
Is it for one parent, or just is the child present? Is it a collaborative kind of thing with the child?
I forgot that part of the question.
Okay.
So no, we will do it with just one child, and with just one parent, and often it's the case that a lot of families come a pretty long distance to come and see us, and so it might not work out that both parents could be there. Of course, if both parents can be there, I mean, that's the most ideal, but we'll take it either way. And I think one parent can come in and really learn the skills well and apply them and teach them to their spouse, and we've seen that work very well. The child is involved some of the time, so I think more often it will be parent-only sessions, but some of the sessions really call for parents. It's a pretty structured protocol for parent management training.
Okay. All right. Thanks for clarifying that.
Mm-hmm.
The big parenting question. When do you ignore a behavior rather than address it? Doesn't ignoring it set you up for inconsistent parenting? And I know myself as a parent, there would be some things I would just look the other way. So I felt like you had to pick your battles sometimes. So would you talk about that a little bit?
Mm-hmm. That is a big question, but an important one. I think that, there's almost a yes or no answer to should I be ignoring what my child is doing. And when I think in a really holistic fashion, I think that things that are going on are best talked about. So if a child has tics and they're pretty apparent, I think that tics being part of the family conversation can be really helpful. If a child has ADHD and it's really getting in the way, I think ADHD being part of the family conversation is really helpful. So there's an acknowledgement of the things that are going on and the struggles that are there. However, when you think about like day-to-day and moment-to-moment life, I think it's really good to be strategic as a parent. So just because tics are being talked about, it certainly doesn't mean that every time a child tics, it's the parent's job to point it out. Ah, that was one of your tics. And so there's a difference between kind of the overall communication and the day-to-day communication. With a child with ADHD who might be struggling in a lot of different areas, I think parents are wise to really prioritize and focus on a few things at once and really ignore a lot of things that aren't the focus right now. And so I think that strategic parenting involves knowing when to ignore and when to pay attention, but to be really open to having conversations that are age appropriate for the child so they can talk about what's going on with them and understand it and become advocates for themselves over time.
Okay. It's not easy, is it?
No, it's not.
All right. I think we have time for one more question, and this has to do with OCD. So TS and OCD are, certainly linked, but there seems to be what someone described as a unique relationship between TS and OCD. And I would be, as a parent, I would be interested in your comment on that. How those two kind of work together, I guess, is what they mean.
Mm-hmm. The easy answer to that is that if you have TS or tics in any major way, you're probably more likely to have OCD than you would be if you had no tics and no TS. You're much less likely to have OCD when you have no tics. And also that if you have OCD and tics, you're more likely to have OCD at a younger age. So these are two kind of common associations. But another way they're thought to be related is a lot of times if you have tics and you have OCD, some of the ways your OCD looks and some of the consequences of your OCD might be a little bit different. So there's this idea of like kind of what we call classical OCD symptoms, and the most classic of the classics would be you're worried about germs, and because of your worry about certain types of germs, you might avoid touching all sorts of things like doorknobs and shaking hands. And if you think you might have been in contact with germs, then you're washing your hands a lot and maybe washing your hands hundreds of times a day. And so this is a classic OCD pattern of an obsession, germs, compulsion, hand washing, avoidance behaviors, not touching things. But a lot of times when you have TS, it doesn't quite look that way. And some of the things that we'll see is children who follow very rigid rules. So things like their food isn't supposed to be touching on their plate, or when they're reaching in the cupboard to grab a cup, there's just the right perfect one that they're supposed to grab, even though it's not clear exactly which one it is. So they're trying to figure out what's the right one or which way things are supposed to be aligned. So there are all these kind of rules that are going on in the world, but if you ask them what it is that they're worried about, a lot of times they might say, well, I'm not really worried about anything in particular, but it wouldn't feel right if I didn't do it. If I didn't touch the corner, that wouldn't feel right. It would feel uncomfortable to me, and I feel like I have to do it. So the obsession part is not as strongly defined. And so this looks more like somebody who has tics with OCD. That all said, somebody who has tics and OCD can very well be worried about germs and be washing their hands, and somebody who has no tics and OCD might be following rigid rules with non-developed obsessive content. But it's sort of like how likely you are to have one or the other. So if you have tics, you're more likely to have certain types of OCD.
Mm-hmm. All right, well, I think we need to wrap it up here. Dr. Ewbank, thank you very much. Really informative presentation, and we appreciate your time. And I'm going to turn this back over to Kelly to tie everything up. Good night.
Thank you for joining our webinar on the NJCTS Tourette Syndrome Clinic at Rutgers. There is an exit survey which we need everyone attending to fill out. The discussion board is open now and available for the next 7 days on the NJCTS website for any additional questions that were not covered in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted to the site before close of business tomorrow. Our next presentation, dealing with holiday stress and anxiety, will be presented by Dr. Michael Ossip. This is scheduled for December 11th, 2013. This ends tonight's webinar. Thank you, Dr. Ewbank, for your presentation, and thank you, everyone, for attending. Good night.